Hi, I am Amy Mooney, and I am primarily a caregiver to a child with severe ME. And I also am an occupational therapist, and I have walked in the hallways of many settings of the school, in rehab setting. So I've seen what traditional therapy does, and it does incredible work for a lot of diagnoses, a lot of illnesses that benefit from OTPT and all of the allied health professionals. So I really do know the principles and the strategies that is offered in traditional settings. And as Dr. Friedman had mentioned, that a lot of the literature does not seem to address what people with ME are going through and benefit them for their care, for their quality of life improvements. And that's where I guess the past has done a lot of overlooking patients that have ME specifically. And I guess, feel that that's going, if that traditional approach continues for people with long COVID, it will continue to miss a whole window of people. And Dr. Azola and I have talked about in the clinic for people with PEM, the traditional approach seems to be missing a core piece, and they struggle with trying to provide the care that is specific for people with PEM. Long COVID, and as we've talked, long COVID and ME are not the same, but long COVID with PEM does reflect a lot of the characteristics of ME. And whether that's diagnosed or not, that is for a physician to determine. But for an occupational therapist or a physical therapist, what you get in front of you is what you are going to work and help. So the diagnosis at that point does not matter. I mean, it makes it a little bit more difficult. You have to do a little bit more research in what you're going to be encountering if there are a lot of comorbid conditions that are added on to the primary diagnoses. So just looking at traditional OTPT guidelines, it does a lot to, the goals are set for improving or increasing activity performance. And then the goal is to restore health and functioning. And with improving and increasing activity, traditionally, it's to increase the strength, the range of motion, endurance, coping strategies, and also addressing illness beliefs. That's the traditional approach. And looking at this iceberg in my image here, that's the tip of the iceberg. And that is what you're going to see in the clinic. You're going to see presentations of somebody that looks weak, somebody that looks tired, and they're going to be struggling emotionally because it hurts, it's painful, and they've gone through a lot of trauma, and they're just trying to be here to get as much help as they can get. But what is out of view is PEM, and that is the crash. And PEM, when it's out of view from the clinician perspective, it's going to happen at home. It's going to happen in isolation, and it is not going to be addressed with any of the goals because it's not being seen. It's being self-reported. And a lot of times patients feel that they're going to be complainers. They're going to be seen as just trying to get attention, or, that it's more psychological based. And that is just not true. It's just not being seen. So that piece of it is, I think, needing to be addressed. But then also the patient is too unwell often to continue with the therapy schedule. And they end up dropping out of therapy or cutting appointments short. So that's another piece. And what happens is the therapist assumes that either the goals have been met, the patient is well, or the opposite, that the patient is unmotivated to continue care. And those, I think, are what is reflected in the literature reviews, that this model is not addressing PEM. And if we look at the next slide, these are what I see in my 7 years of being a caregiver. And it is to flip the iceberg. It is to look at PEM as the primary issue, looking at the crash and looking at that in isolation, and the rest will follow it. Strength, endurance, all of that will follow once you address PEM. And so my guideline is to flip the iceberg. It's managing symptoms, managing activity within the limitations of PEM, and that restoration of autonomy will lead to improved quality of life. And with those simple, but not so simple goals, that's where I think, in my view, people with ME, people with long COVID and PEM will benefit. So looking at the very, very quick outline is prior to the session is to address in a telehealth and a virtual call is to identify PEM and look through screening tools, questionnaires, checklists. I think the DePaul questionnaire that Lenny Jason has put together, his team, is phenomenal. I think that needs to be used with most clinicians, and also using that if centers want to come up with their own, it needs to be at least used as a model. Developing PEM specific treatment plans, and those would be for symptom management. And we know that every single person with PEM, their symptoms are different. These are unique, and they also will change over time. So what somebody presents with one day will come back or speak with a clinician over telehealth with an OT or PT. They may have a different list. That number, the one that was maybe third on the list is now number one, and they alternate and switch around. So the symptoms are to be managed through pacing techniques, also for modifications and adaptations that OTs are phenomenal working on ADLs, IADLs, and then also working in the environment that the patients or the people with ME are living. Where's their work? Where's their home? What's their school like? So looking at their roles. And then also patient and caregiver education is important. You need to have the whole team that helps the person manage their symptoms and provide their support involved in every step of the way. And how to do this is, and I know I'm running through a lot of these things because this is where chapters can be written on each one of those points. Utilizing tools and strategies within the limitations of PEM. Frames of reference. Frames of reference are what the OT community loves to use. This is our bread and butter of our profession. And we have 25 some odd frames of reference that we use. And these are just an example. It's sensory integrative therapy, proprioception, and that's usually the proprioceptive is a neuro framework, and then the biomechanical and cognitive behavioral. And that's where I think if we look at the debunked PACE trial, they only seem to really want to focus on the biomechanical and the cognitive behavioral frame of reference. And we know that is not where people with ME and people with PEM are going to benefit. They have, yes, it's needed in the bigger picture, but looking at what their sensory component, what the neurological components are doing, what the symptoms are. Maybe they're not presenting as weakness, they're actually presenting as sensory impairments. The lights, the sounds, the touch is too stimulating for the nervous system. So using a biomedical approach is going to be putting the cart before the horse. They're not ready for it yet. So that's what the OT and the PT on the team needs to look for and adjust frames of reference and how to use the tools that they have in their toolbox. Guidelines and programs, and these are just examples. Heart rate monitoring, like Dr. Friedman had said, but we're also looking at the anaerobic threshold. Sometimes people are, if they are very severe, a tiny bit of stimulation is going to put them over the top. And it might not even be movement. It might even be having a bowel movement. It might have thoughts or emotions that are really going to be draining on their system. So looking at what their anaerobic threshold is, how high it is on the graph, then also how narrow it is, because it might just need a tiny bit of stimulation and it throws it over the anaerobic threshold. Also looking at POTS programs, orthostatic intolerance programs, Ehlers-Danlos programs, and also craniocervical instability. Craniocervical instability has a history with autoimmune diseases. Rheumatoid arthritis has a history. If you do a literature search on CCI and rheumatoid arthritis, you will find that having cervical instability is not unusual. And just knowing that people with ME are now showing signs of cervical instability, that also needs to be looked at for people with long COVID. If they have some sort of POTS and autonomic dysfunction, there's a history there. So that needs to be looked at and researched as part of the process too. Flexible care, that's one-on-one sessions. This is not mass production of the care, and it needs to be done in a small setting. It can't be done in a big therapy center. It has to be done in smaller spaces. Telehealth, virtual care is imperative. And then also recording the program, putting it down on paper and also video recording, because patients need to be able to access those instructions on their own time when they can handle that information. And finally, consulting with your providers. Just because an OT and PT has great things to say, it needs to be communicated to the pediatrician and to all of the primary care and specialized care teams. This cannot be on only the caregiver's shoulders or the person with ME, because we don't have the bandwidth to have all of the complicated discussions. So it needs to be put down in form and then sent to all the different providers and work, and then school. And I think school can be a whole nother chapter in itself, because kids get ME, kids get long COVID, and kids really need help with their own specialized needs. Thank you.